we live or not yet?
Not yet. I'm gonna tell you. Waiting for it. Yes, we are live. So welcome everyone to the live stream, and welcome Dr. Jordan Grant and Gil. Welcome, guys.
Thank you.
Howdy.
Hi there. So we already got some questions in the chat box and on Facebook. So we're going to start off with those.
Oh, somebody's mic is.
So we already got some questions in the chat box. Whose mic? Who is talking?
I don't have the live stream open, so definitely not mine.
Yeah, it's not mine.
It was mine. Okay, they're all set now.
Slacker.
Okay, so let's have a look at Facebook. So somebody asked your guys' opinion why HCG is better than gonadorelin, or maybe just more info about gonadorelin for all the guys stuck using it because our clinics switched. So what's your guys' opinion? I have none.
You want me
I'll let Gil address it first, because I think you have more experience with it. I know the mechanism.
Yeah, I'm gonna take it as a two-part question. Part one is going to be availability of HCG. I want to clarify the whole HCG is no longer around thing. It was not banned by the FDA. It was reclassified. It used to be something where if you had like 50 amino acids, it was classified as a protein, and now they knocked it to 40 or something along those lines, where now HCG is considered a biologic. So it's just classified differently by the FDA. So now the drug manufacturers or compounders have to address the production of HCG differently than before. Before it was a peptide, and it's no longer a peptide. So in order to produce or manufacture or compound a medication that is now classified as a different group, the pharmacy must be licensed to compound the medications of that group. My understanding from speaking with a few pharmacy owners is that in order to compound biologics, you must have a biologic license and certain equipment and certain sterility testing. And this was nothing more than a push to sell more Pregnol, which is the name brand of HCG. I believe Jordan Merck is the producer of Pregnol, and it's used as a fertility drug. A vial of Pregnol is going to cost you about 3 times the cost of HCG. So because HCG became popular and prevalent as a result of TRT supplementation alongside, they felt that Pregnol is being impacted, and naturally the lobby said, well, we can't ban it, but we can reclassify it, and by that way we can sort of ban it. So pharmacies are still making it so long as they have a biologic license. Now, if your clinic does not have an account with a pharmacy that has a very expensive biologic license, they're going to tell you HCG is no longer available. It is available. We deliver it daily to patients through my clinics, and it is just a matter of them going to the right channels. That out of the way, the difference from a medical perspective between gonadorelin and HCG. So gonadorelin, from my research, and I haven't experienced it with patients because we still use HCG, it is a step above HCG when it comes to the chain of command, okay, of where do we address the production of testosterone. So if we think of the master gland in the HPTA, or the endocrine system for that matter, it's the hypothalamus. And then below the hypothalamus, you have its assistant, which is the control panel. And that is going to be the pituitary, or anterior pituitary in the case of the HPTA. And then from there, we go on to the testicles. So when the hypothalamus releases a gonadotropin releasing hormone known as GnRH, that then signals your pituitary gland to go ahead and produce luteinizing hormone and follicle stimulating hormone, which then act on the testicles, which is the actual factory of the process. HCG is an analog. Analog simply means a mimicker of LH, or luteinizing hormone. So when we're administering HCG, we are telling the testicles, go ahead and produce testosterone, and the pituitary no longer has to function with the LH release. And in turn, the hypothalamus no longer has to release GnRH. When we take gonadorelin, we are essentially mimicking GnRH because it's a GnRH analog, which then hits the pituitary and tells the pituitary, go ahead and produce LH, and then in turn go down to the testicles for testosterone. Here's the problem. When a man has secondary hypogonadism, not tertiary, not primary, secondary, the failure is at the pituitary level. This means the pituitary gland does not secrete sufficient levels of LH, even though it is being stimulated by the hypothalamus. How do we know it's being stimulated? Because the low T will not shut off that loop, yet the LH is insufficient. So gonadorelin is only going to ask the pituitary to do a job that it's already failing at doing. So guys with secondary hypogonadism are not going to benefit from gonadorelin in the same way as they will with HCG. And guys that don't have secondary but have primary hypogonadism are not going to benefit from either one because the testicles have already failed. So for me to take a step from the failing point and go backwards, everything behind that line is no longer going to be acting in the way that you expect of it. So I'm not going to say gonadorelin is not better than nothing. I'm just going to say that to me, it's not a replacement for HCG because of the mechanism of action being slightly different. So if you have anything to add to that.
I totally agree. I mean, we do know sometimes you can push those pathways if you overwhelm them with that medicine, right? You might get a little bit extra out of it, even if the pituitary is kind of, not, we won't say failed, but on the, it's not running up to speed. So you might get a little push, but I agree with you. I don't see the reasoning behind it. The only thing I could see is if maybe if you had completely normal function, your guys who are just taking testosterone that didn't have the failure, right? Like they're just taking it, then you might get the benefit of it. But yeah, if you actually have secondary or primary or combo, it's not a great option. So, yep.
Staying on the topic of HCG, someone asked on Facebook last post there, basically, is preventing testicular atrophy from happening in the first place better than fixing it after it has happened with HCG? So should you start HCG immediately?
What do you do, Gil? I at least have guys usually dial in their testosterone for a few, a couple months. I mean, depends, but I don't think you're losing that much 6 to 8 weeks before you start HCG. But everybody's different. I don't know the answer, honestly. It's usually just a conversation I have with the patient to see what they want to do.
I think this comes down more to a subjective assessment where the patient has to dictate to you what it is they're expecting out of this therapy. Yeah. What is their priority? This comes down to age, family history in terms of, are you married? Do you have children? Do you want more? Mm-hmm. Do you care about testicular atrophy? What's your cosmetic priorities here? Is it a matter of increasing or decreasing ejaculate volume over time? Is it a cosmetic issue that's going to cause anxiety? Is it a fertility concern? All of these things are so specific to an individual that there is no cookie cutter approach, as there really shouldn't be with anything when it comes to hormones. Unfortunately, we know that's not always the case, but everything should be down to the individual patient and their needs. Now, much like Jordan, and I will credit him with the idea of actually doing this. We used to, a while back, start guys who are younger and want to maintain fertility on T and HCG right out of the gate on day one. And after speaking to Jordan for a while about this, I came to a conclusion that I think he's right about starting guys on just T initially, because ultimately we're looking to replace and optimize testosterone. So let's go ahead and put the cypionate in the formula. And then at the 8-week mark, when we do the reevaluation, we can always go in and drop the HCG. I don't think that an 8 or 12 or 16-week period of having no gonadotropin mimicker in there is really going to take such a drastic effect when it comes to a lifelong of actually optimizing someone. So yes, I think the less cooks in the kitchen are going to help you determine quicker which one of them is actually doing a better job of preparing a meal. So we will add HCG in at that first follow-up, assuming we're happy with the way the progression of the treatment is going overall. But I think more this question comes to not really, do you start on day 1 or 2 months out? I think a lot of guys are concerned if do I kind of stay off HCG for 3 years and then decide I want kids and jump back on? And I think that's really where we have to look at it and say, look, I tell guys all the time, if you think there's a slight chance of you wanting to A, maintain fertility, B, prevent testicular atrophy and everything else that goes with the side effects of supplementing cypionate, go ahead and put the HCG on a drizzle faucet. There's no harm in taking 250, 350, 400 IUs twice a week, just kind of like as an aside, so that it is there for you. Why do you want to run a risk of 5-10 years down the road, finding out that everyone is wrong and no, you're not getting your fertility back? Just keep the faucet dripping alongside. There's no harm in that as long as it isn't giving you adverse reactions.
Yeah, I totally agree. Because I wish I had a crystal ball. Every guy, we have this conversation all the time. Every guy's different. We know freaking bodybuilders who are on everything you can imagine and they still get their wives pregnant, or they recover fine after 10 years or 15 years of use. We know guys who do one cycle and they're screwed forever, right? So I can't give people the right answer there. We just have to guide them and say, this is a possibility. You have to decide what's best for you and what risk are you willing to take. Everything comes down to informed consent in this game, right? So, but I agree with you. I don't, and again, 8 weeks on one person, yeah, it might cause an issue, but they probably had something going on already, or they may not have responded. If we hadn't, dove in and seen what the primary cause was, they may have had testicular failure. Well, HCG is not going to matter anyway. So, but you don't know that after the fact, like what was the cause, unless you worked it up ahead of time. So I'd rather get somebody dialed in with one variable, see how they feel, because that's the issue. I see a lot of guys right now coming to me who have originally been put on a myriad of things, and then they're trying to tweak stuff left and right, but they still have all these, they got HCG and AI and pregnenolone, DHEA, and they're all tweaking them. And it's like, why don't we just figure out how you feel on testosterone? And then once then add in the HCG and see how you feel on that, and then tweak that or whatever. So I'm just a
on the same topic. Is there any over-the-counter supplement that might not be HCG but has similar effects?
There's no LH analog over the counter. You're not going to find pituitary, reactive type of a drug or a supplement. Really, you will find stuff that is suppressive. Yeah. And the only reason it's over the counter is because, supplement market is unregulated and people lie about what they put in their products. But, if you look at all the SARMs and some of these test boosters and all this other nonsense, a lot of that stuff is suppressive. And we know this because guys will come in suffering of low T symptoms, and then we will go ahead and run their labs after their initial assessment, and we will ask them what they've done, and they'll list a slew of, various different boosters they got online at GNC or Vitamin Shop or whatever. And they come back with an LH of 1.5, and they're obviously mildly suppressed or tremendously suppressed. And they'll say, I did this a year ago and I never felt right after. And a lot of this stuff will have things in it that you don't. Look, manufacturers want you to keep buying a product. And if it doesn't have some level of a stimulant or some sort of a positive effect on you, you're just not going to buy it. Placebo is very real, but placebo is not going to change your physique. Placebo is possibly going to make you push harder in the gym and maybe want to diet a little more, but it's not going to change your physique. So the guys buying these supplements still need to have something in there that works. The problem is what happens when they stop. They're now suppressed. They're going to be bound to either TRT or a kickstart, assuming they can regain their natural production. And in short, no, you're not going to find something over the counter on Amazon that is going to give you a gonadotropin or luteinizing hormone mimicking effect, unless I'm wrong, Jordan. I mean, I just haven't seen anything like that.
I haven't seen anything. If it worked, it wouldn't be sold over.
If it worked, somebody would be selling it to you with a prescription.
Exactly. That's how I feel about most things. So,
what's your guys' view on N-clomiphene to boost testosterone?
I haven't used it yet. I mean, I've looked at some of the research on it, and it looks promising as far as avoiding maybe some of the side effects from Clomid, but it's still, at the end of the day, it's the same principle as.
The last time I looked at N-clomiphene was when it was still being considered for approval. And correct me if I'm wrong, my recollection on it was that it basically took the part of the clomiphene that aromatized and eliminated it. So it's essentially a non-aromatizing SERM. Is that correct?
I don't, it's a stereoisomer of Clomid. So I'm not sure, actually. I just thought it only blocked receptors in the hypothalamus, and that was it.
So it's extremely selective then. Right.
And so it's really just trying to stimulate those pituitary hormones.
I'm not a fan of taking an oral medication as a replacement therapy.
No.
For me, all of these, self-stimulating analogs like Clomid, tamoxifen, any of these, to me, they're more of an acute therapy. This is not a lifelong, this is not a replacement for TRT. You don't go on N-clomiphene for 30 years.
No.
This is a Kickstarter. So sure, if you want to kickstart, and N-clomiphene alleviates some of the floaters or mood swings of Clomid, by all means, use it, get the hell off and see if your LH recovered. If it didn't, you're still a TRT candidate in my book.
100% agree. It's not a replacement. It drives me crazy. All the guys lately that are joining the group, and a lot of them are from Europe, and I get it because the doctors over there aren't. They just want to, and they do it here too, though. Endocrinologists, urologists, they're like, yeah, we're just going to get you on Clomid, and that's as good as TRT. And
those darn urologists.
For sure. Get me started. It makes no sense. The replacement for low T is T. If you're not concerned about fertility, if you're not trying to do a kickstart, whatever. Otherwise, take testosterone. Just drives me insane. I mean, I get a little snippy on the forum with just because it's all the time now. And it's like, why are you trying to do all this stuff that you don't feel better? It's not testosterone. And you're adding in a synthetic chemical instead of, I mean, yes, testosterone is synthetic, but I mean, not a natural substance, right? Clomid is not something naturally found in the body. HCG isn't either, even though it mimics LH. It's not LH. So you're doing all this stuff that's not even close to natural. Because, well, yeah, but my production will be natural. So what? You're taking unnatural crap that's going to come with side effects, and most guys don't feel as well. So
hey, when a diabetic becomes hypoglycemic and he's at immediate risk for low blood sugar, do we give him fats, which will then be converted into glucose, or do we just give him glucose? Right. So why are we taking 4 steps backwards in order to convert this into this, into this, into this, so we can have testosterone? Heck, take testosterone, call it a day.
Yeah. It's not hard. I don't know what this fear of testosterone, why it still lingers like it does. I don't know.
Because it's steroids. It's bad.
It is. Yeah, freaking.
A lot of questions are coming in the chat box, guys. Thanks for the tips too, for those that do a super tip. Hi, Danny Bossa. He's in the chat box as well.
Yeah, he is.
So we got a
Danny hasn't tipped me in a long time. Just
yeah, Danny, give us a tip, man. We got a question from a strong nerd. He says, any over-the-counter supplements that you recommend to assist with TRT, even if someone is resistance training, doing cardio, sleeping enough, and has the proper nutrition, just for general health while on TRT? Thanks.
Can I run down a very rapid list of non-all-inclusive supplements that I think everyone should be using? And I say non-all-inclusive because I'm sure I'm going to leave out 1 and 2, and then someone's going to say, well, what about this? Why don't you recommend this? Well, I probably do. I just forgot to mention it. Okay, vitamin D3. Unless you live in the desert with your shirt off all day, most people are deficient, and it is an important hormone. It's actually a pro-hormone. So vitamin D3 is super important. Everybody should be, depending on where they're coming in, where they live, et cetera, 5 to 10,000 IUs a day, ballpark. Fat-soluble vitamin, take it with a fatty meal or buy one that has oil infused into it. Vitamin C, all right, anywhere from 1 to 3 grams a day. Some guys may benefit from a little bit more. So you got that ascorbic acid, could take orally. If you're taking an injectable format, divide the dose by about 10, 8 or 10 to equivalent to oral dose. So those two. You got NAC, N-acetylcysteine. I know there's a whole push now with the FDA to maybe kind of ban it or regulate it, which is a damn shame. I buy this stuff in bulk. I just happen to have it here. NAC, I buy like pounds of it, and I make my own NAC capsules. So I take 600 milligrams morning and night. Precursor for glutathione, potent antioxidant, good for the liver. Liver metabolizes most drugs and foods, and keep your liver healthy, and you'll be happy. So NAC, vitamin D, vitamin C. Berberine I like better than metformin if you need to improve your insulin sensitivity, non-prescription drug, no GI issues. So berberine hydrochloride is a nice one. If you want to get into some performance stuff, we already did a whole video about creatine monohydrate and its effects on myostatin and intracellular water retention and whatnot. Just make sure you're well hydrated, check your creatinine levels, make sure your kidney function is good. L-citrulline is one that gives nice pumps. If you're going to go citrulline or arginine, these are just aminos. I mean, but he did mention performance. Again, I'm sure I'm leaving a ton of stuff out. Fish oil, omega-3, fish oil, or krill oil, 2,000 milligrams a day minimum. Some guys could benefit from 4,000. Overall, lipid support, joints, etc. Selenium, 200 milligrams a day, good for thyroid support. Iodine is a good analog for T4. There's a ton of stuff out there. ZMA, very important before bed. Zinc, magnesium, B6, great bedtime supplement. 30 to 50 milligrams of pregnenolone before bed. For guys on TRT, pregnenolone and DHEA levels tend to drop. Pregnenolone is upstream from DHEA. That can help you with some sleep along with ZMA. There's so many. I mean, we can go about supplements for hours and hours, but that's pretty much a list of stuff that I take. And I think everyone can benefit from, as long as they do it cautiously and they understand what's going on.
Jordan, something to add?
I don't have much to add. I take all that. I actually stopped. I need to take ZMA again. I do take vitamin D3 with K2. There's some decent data on K2 being.
I did forget K2.
Yeah.
However, K2 is one of those that you put an asterisk next to because make sure that you don't have any contraindications. If you're on blood thinners, heart medication, etc., K2,
yeah, it shouldn't. yeah, it shouldn't interfere with that, but yeah, I agree. I take curcumin just because. Other than that, is daily cialis a supplement?
It's not a supplement, it's a medication. Medication.
I know, I was kidding, but I like it.
I like it too.
Yeah, I consider that pretty important for a lot of guys. Those are the two biggest things I prescribe: testosterone and daily cialis. I mean,
Same.
Yeah.
It's what we put out the most of.
it works. So
It does. Keep it simple, right?
Right.
KISS. Keep it stupid simple.
yeah, I agree.
Scott asked, he's thinking about trying HCG to help with better orgasm intensity. He's using cream now and feeling otherwise great. 250 every other day, is that a good starting point? Could too much DHT be an issue? So worth switching to shots?
Too much DHT can lower SHBG. It can lower E2. It really comes down to how he feels. And I would say, when you say better orgasm intensity, you have to contrast with what it was prior. I mean, did he have good ones and then the volume decreased, the intensity decreased, or was it always kind of lackluster and he's trying for a boost? HCG is not going to necessarily give you a boost. It's probably just going to restore at best to what you had previously. But yeah, if you've been on TRT or any sort of replacement exogenous hormone for a long time and you've been suppressed, expect a decrease in volume and possibly intensity. It can't hurt to try. You don't necessarily have to go every other day. It is a very fast acting med, but fast acting doesn't mean fast or short lasting, because the activity that it generates can have a lasting effect. So twice a week on HCG is sufficient. You don't have to really pin it every other day, unless you're really looking for a kickstart protocol from a fully suppressed state where you're coming off hormones. If you're looking to add it to your TRT, twice a week should be sufficient. 350, 400 IUs, you can go up to 500 as long as you're not feeling poorly on it. Give it a shot for a month, and if you don't like it, discontinue and it's out of your system. But yes, it should help with volume.
Mm-hmm.
Jordan?
Yeah, it's not something I ever really, people don't bring it up that much. My patients don't. So it's not, and like I say, I'm open to whatever. Like I always tell patients, I'm more of a facilitator, a guide. If they want to try something that's safe and they're dialed in on testosterone and they say, hey, I'd like to try some HCG to do whatever, okay, let's try it, and I can't always explain all these mechanisms about sensitivity with HCG and all this. I've looked, it's not clear cut. So the best way to know is to try. And I don't think you're going to hurt yourself with a small amounts of HCG added to your TRT.
Unless you use an 18 gauge.
Freaking harpoon. Yeah, don't do that. I had one patient doing that. I was like, don't do that. The DHT thing with the cream, I know that, I'm probably the one that it's not as,
Not as potent as people like to believe.
Well, DHT serum level is not telling you squat. Okay, like it's not. It's just like E2.
Another paracrine hormone. That's
your DHT is
enzyme
made locally in the tissues, so that level you're getting is not necessarily reflective. I have a guy who switched from creams to injections, got his blood work. His total was less on the injections, but his DHT, he checked it himself, was higher on the injections than the cream. So it's not all about the DHT with the cream. The amazing thing with the cream is usually you have a higher free testosterone level. Because you're doing a fast acting daily or twice daily administration, right? And so that's the deal with a lot of the, I think, boost guys see with the cream is it's potent for a lot of guys. If they have a non-existent, layer in their scrotum, stratum corneum is thinnest in the scrotum, right? That's why we use it there. And they're just like absorbing the hell out of it. They get high free T and they feel that more. So it's just that high androgen. I don't think it's the DHT. That's just my spiel on that. So.
And this is easy to test anecdotally by just administering someone a DHT and seeing if they're experiencing the same. And because we know the DHT orals are significantly more powerful than the conversion you get out of a cream.
Yeah, definitely.
So I will surely mispronounce this. It's a varicocele. I don't know how you pronounce it.
Varicocele.
Can it lower testosterone levels? Does test levels increase after varicocelectomy?
Can, if it's a significant enough varicocele that's causing a lot of stasis, and usually it's bilateral. One side. We do repair, unilateral ones just for fertility concerns to give a guy the best if they're having trouble, with fertility. A lot of urologists will repair a single-sided varicocele to help with that. But if it's a subclinical one, I doubt it. You're not going to I wouldn't repair a subclinical varicocele, one that's just found on an ultrasound, that you can't even palpate. And so, yeah, I mean, levels can absolutely improve if you have pretty significant bilateral varicoceles. Sperm count's not always going to improve. It can. Fertility rate doesn't always improve. So that's the thing. You will see some improved semen parameters, but it doesn't always lead to improved fertility in everyone.
Do you find that the fertility lack of improvement there is due to the fact that some of the intra-testicular cells responsible for spermatogenesis are essentially killed off by the lack of blood flow over time? And
I don't know, because you do see an improvement in the parameters. So you would think, okay, your sperm count's gone up, plus the morphology and everything. You don't see you do see a lot of, because when you have a varicocele, you see what's called like these stress effects on the sperm, right, from the varicocele, and that gets better. So it does make me think that the Sertoli cells and everything else are functioning better. But I think it's just because there's more to fertility chances than just improving those parameters. It could be something on the female side. There could be
you do see sperm count increase. Could it be motility that's not?
That's what I say. You usually see all those parameters improve, but is it enough to get back to an ideal state? Not always. So, yeah. And again, I don't even do varicoceles here because nowadays the gold standards of microscopic subinguinal varicocelectomy, which takes a microscope and somebody who does a lot of microscopic surgery. So I just send them out to a fertility trained urologist to deal with that. I have a buddy in Shreveport that does it. A lot of guys in Dallas. So we don't even have a lab here in Paris, Texas that does a semen analysis. So fertility stuff, I can get the ball rolling, but I just don't mess with it that much. So.
I know I'm skipping some questions, guys, in the chat box. It goes very quickly. So if I missed your question, please repost it again. And someone did repost, and it's about post-finasteride syndrome, specifically penile shrinkage and retraction. Would you try HCG and Clomid first, or jump into TRT to help with that? You have probably some experience, Jordan, no?
Right up your alley. I know you hate finasteride, and I know it's a very, very popular drug in urology at the first sign of BPH.
It kills me. And I'm not an expert in post-finasteride syndrome. And just this year, I've seen maybe 3 guys that have had this issue. And it's made me look into it more, but there's not a lot of good data on it. The penile shrinkage thing, I mean, to me, it's just a lack of that, penile health that you get from blocking the DHT. The interesting thing is, though, a lot of these guys with PFS, when they've come off, their DHT levels serum are fine, right? So it's, we think, well, then it's not an issue, but I don't know what their penile DHT levels are. I think from what I've seen, there was somebody was outside, jumping to Clomid and HCG, it doesn't work. I mean, unless it's a young guy, right? That's reasonable to try a kickstart and all that, but realizing it's a kickstart, try to if their testosterone is low, and usually they are. I see these guys and their testosterone in the 400s or something like that. They're symptomatic, but the best symptom resolution that I've seen is with testosterone. It just is. And then you do have the fertility concerns because these guys are young, but I've heard these stories. I've looked at the PFS forums, which are a freaking dumpster fire of bro science. And everybody's talking about taking Proviron because they want to take all these DHT derivatives when it's like, I don't think DHT is the issue. The main issue with finasteride are the neurosteroids that are blocked from blocking 5-alpha reductase. It's not just the DHT. That's why they feel like crap. The penile shrinkage stuff, I don't know. I'm not being flippant about it. I think some of that's in the head sometimes. You do get a little bit of maybe decreased girth or something like that. That's where, again, something like getting them on a daily cialis just to restore their confidence and their blood flow down there, I think helps. Get them on testosterone, that helps with the tissue health. And then we figure out the fertility side of things. It's a big problem. I mean, I don't see it a lot. I've had a few guys. One came to see me, and then he ended up, I think, talking to Dr. Mark Gordon about his protocol, which I think is Clomid. He didn't like that. So then he went to Mayo Clinic, and he said they were just not helpful at all.
Isn't Gordon the one that said that applying creams to the penis will increase size?
Yeah, I think so. So, yeah. I'm not going to get into that. So we all have our own opinions about things. I mean, you got to try. These guys are desperate, and I get it, right? They're young guys, and they're desperate. They've lost their sex drive. They feel like their penis is shrinking. But what I've seen, the worst of them is that they overthink it. They just get online and they start diving into these forums, and they're getting mixed signals, and so they just want to try everything at once, and they think it's going to get better, within a matter of a few days or weeks, and it's not. They've got to ride it out. it's a big deal, but you've got to be patient, and you can't flip out about it, and you can't overstress yourself by reading forums and bad advice, and because you're never going to feel better. And this applies to testosterone replacement guys as well. You can't constantly be checking differing forums that are completely opposed to each other, and then you're confused all the time, and so you're tweaking your protocol all the time. You're never going to be better. It doesn't matter what you do. You're going to constantly be, you're basically a hypochondriac at that point. So that's what I do see with some of the PFS guys, because a lot of them are young, and they start maybe getting a little male pattern baldness in college age, right? And they're 21 or 22, and they take Propecia, and it causes some major issues. So I hate 5-alpha reductase inhibitors. Hate them.
I'm not a fan of most enzymatic inhibitors unless the priority of the intervention supersedes how you feel temporarily. Yeah. I mean, no one can say chemotherapy is good for you, but we're trying to save a life. Yeah. So putting someone on a inhibitor of a natural physiological process long-term.
Yeah.
Just a silly.
And that's honestly still a concern of mine with cialis, right? It is. That's what it is. It's blocking a pathway. I haven't seen it change the way people feel, but is there a health detriment somewhere hidden that we don't, maybe? I mean, right now it doesn't look like it, but that may change, To me, it was worth it for the benefits and the supposed, endothelial health benefits. I mean, that may change in 10 years. They may come out and say it's freaking toxic. And I mean, but because I agree, it's you're blocking something the body does for a reason. And it's
no different than statins. It's my right with statins.
I agree. Toxic, horrible. It's just bad medicine. It's just bad thinking. And that's a whole different topic, right? But that's how researchers and everybody's just looking to make more drugs to do things that they don't even know that they're addressing the cause. Actually, they aren't addressing the cause of the issues. They usually misinterpret effects that they find as causes. And so that because they got to make a drug, right? So they may be seeing markers of things that tell you something's going on in the body, and then they try to make a drug to kill that marker. It's like the marker's there to help you. It's to tell you something's going on underneath. It's just moronic. It drives me crazy. It really does.
Yeah, masking symptoms is the worst way to treat anything.
Yeah, but that's Western medicine. It is. I hate to say that. I mean, I'm an allopathic doctor, but I'm not of that mindset anymore. Every patient I see, when I see their medicine list, they come in from their primary care, and they're on 20 freaking things that are just masking symptoms. Symptoms are important. Symptoms are telling you there's something wrong underneath. You need to find the cause. And we don't do that. We just give them drugs.
It's like the guys with the liver disease that have an SHBG of 120. And their first question is, what can I take to lower my SHBG?
Exactly. It's the same. It's like guys I see, right, with an elevated PSA, and they want to know what they can take to lower their PSA. I'm like, the PSA is not hurting you. The PSA is a marker. We need to find out if it's a problem or if it's just your PSA, right? It doesn't matter, but urologists do this crap all the time. We got to put you on finasteride, get that PSA down. What? Like, it just kills me. It really does. It's a horrible way of thinking about things, and I don't jive with that. So.
On the topic of cialis still, is there a downside to recreational Viagra cialis use? So I guess that is a higher dose to get erections once in a while.
You need to define the word recreational. It's a social term. It doesn't tell us anything. It doesn't tell us dose, frequency, or reason. What's recreational for one guy is therapy for another. Are you taking it because you're bored, or are you taking it because you have a need and it fixes the need? Are you taking it because you want pumps in the gym, or are you taking it because you have erectile dysfunction? Yeah. Taking 100 milligrams a day, or are you taking 5 milligrams a day or every other day? I mean, if he can address that question a little bit better, I think it would be a more responsible answer.
We might come back to that one then. How to tell if I'm finding a good TRT doc or a money-grabbing clinic? Gil, you already talked about that.
We have a whole video on this. I mean, at the end of the day, if you have any suspicion, chances are you're probably right. And if not, watch a couple of videos, jump in the group for 3 days, and you'll probably have your answer.
Okay. Any advice on sleeping? Since starting TRT, I have trouble sleeping. Before TRT, I slept well.
That's a hard one.
How long is he on? What doses? What else is he taking as part of his protocol? Is it due to anxiety, stress, and other factors? Mm-hmm. Again, there's a lot more questions that need to be answered here rather than a blanket statement.
Mm-hmm.
Yeah, it's a tough one. Some guys, it's just an early side effect and it gets better when they're on. Could be too high of a dose.
Guy's taking 200 milligrams a week, and he's taking 500 of HCG twice a week, and he's taking 3 milligrams of anastrozole, and he's been given 23 gauge 1.5 inch syringes. I wouldn't sleep just thinking about it.
Yeah. And a lot of it, I think, is anxiety too. When guys are early in the process, they're just thinking about they're on TRT. I don't know. They worry about side effects, right? How many posts do we see where guys like are asking what bad side effects they should expect?
Yeah, it's an anticipatory response.
Yeah, it's nocebo.
Everything is under the microscope. All of a sudden, it's like, hey, I noticed since I started TRT, there's more traffic on the way to work. You know? Seriously, it's like, let's blame everything on this. So
yeah, really bad correlation.
A lot more. What guys don't understand when they come in the groups, and I understand this, they just want answers. A proper assessment is not done over a Facebook post. You're looking for general answers, great. You're looking for an individual answer. You're looking for someone to assess your specific issue and advise you accordingly. This is a 40 to 60-minute process at the very least, and that is just over a conversation. That doesn't even include looking over your medical history and whatnot. So you'll notice, really don't give any resolutions in the Facebook group because I think it's irresponsible. People take it as blanket statements, and then they'll quote you 6 months later. Well, you told this guy who experienced A, B, and C to do this, and I'm experiencing A, B, and C, therefore I did that and it didn't work. You were wrong. Well, I never told you to do it. Yeah. So I just don't like to answer specific type of detailed questions without having all the facts. And that's not trying to give anyone a hard time. It's just trying to be responsible about it.
Yeah, that's what consultations are for. And that's why you pay people to do that. I mean, it really is, because it's a liability.
You're not paying us to regurgitate information 15 times a day. You're paying us to study you individually.
Yeah. I mean,
any concerns with long-term high free T, total T levels regarding cardiac remodeling? This would be pertaining to symptom resolution and regarding testosterone only, no AIs.
Again, he used the word high. He didn't give specifics.
He put high between.
What's high to my primary care is 800. What's high to me is 2,500. I mean, probably. I mean, if you're going to live in the 3,000 range for 20 years, I would be very surprised if you don't experience some level of LVH, maybe cardiomegaly, maybe some plaque buildup, arteriosclerosis, maybe some hypertension over time. I would be surprised if you live that long. And again, you may be genetically predisposed to being totally fine until you're 90 years old. Over the course of many subjects in a trial of grossly elevated T levels, yeah, I would think that you're probably going to you're going to trade years on the back end for quality today. Probably.
Maybe.
Probably. Yeah. Big probably. Yeah. Jordan, agree?
I do. I mean, again, it's all relative, right? Where's that line? Where does it become pathologic? We don't know. I mean, that's why, and again, most guys don't need to, I don't see guys needing to be at 3,000 to feel better. I don't. On average, I'd say, but I mean, we use free T now, talking about 25 to 40 or 25 to 50, somewhere in that range. But for total, on average, on the bell curve, 1,000 to 1,800, somewhere in the middle in there. I'll usually see guys with symptom resolution, and they go higher and they don't feel as well. That's me too. Like, I know if my free T gets over 45, I don't feel as well as I don't feel bad, but I don't feel right. You know what I mean? There's a fine line there.
I could tell you when my free T was over 100, I couldn't sleep well.
Yep.
I didn't feel well. I had anxiety. I was short-tempered. I would hyperventilate.
Yep, me too.
And I just, my pulse was higher. I didn't like it. It was done for a reason, for a short period back in the day, and I didn't like it.
Yep,
so,
same here. I played with high doses, and I know I don't feel as well. I know there's guys on bodybuilding forums like, I feel amazing on a gram a week. It's like, okay, but most guys aren't going to feel that way. And we
feel amazing during your workout, and then the other 23 hours fighting.
Yeah, you feel amazing because you're seeing changes in the mirror and it's exciting and all that, but long term you don't, because your penis doesn't work and you don't sleep, and I mean, just you start chasing your tail from side effects. So I mean, we've got one study on 600 milligrams a week for 20 weeks, no detrimental effects, but 20 weeks is nothing compared to lifetime. So you do have to, I mean, testosterone still, I think it's safer than people make it out to be, right? But there are going to be consequences going really super physiologic for a long time, in my opinion. That's not a fact. That's just an opinion.
No one bats an eye over a diabetic injecting insulin. Yet we know that if I move a decimal point over one spot on an insulin administration, I will kill you.
Yeah.
And you can give me 3 vials of testosterone today and I'll have a bad week. That's
Yeah.
bad.
Yeah. So it's more of a chronic thing. And there's other factors that are going to come into play. What did you do when you were on that testosterone? How did you live? How did you eat? How did you work out? How much weight did you gain? All kinds of stuff. So everybody's different. There's guys that have taken high dose testosterone for 30 years and are fine as far as we know, and so anyway.
Will a ketogenic diet kill my free testosterone by increasing too much the SABG?
Not if you're on T.
Good
If you're
point.
natural, absolutely. If you're in T, you could adjust your dosing and frequency accordingly.
Is keto diet a good idea, Gil?
Time and place. If you're insulin resistant, absolutely. But keto, understand, can be done by going Atkins, or it could be done by actually eating avocados, coconuts, almonds, chicken, beef, fish, asparagus, stuff of that sort. You can be low carb and still eat a nice proper diet like we would do like on a show prep, or you can go eat greasy bacon all day and 17 eggs and say I'm keto because I got no carbs. So if you are insulin resistant, running 4 to 8 weeks of a ketogenic lifestyle is probably going to improve your diabetic markers and lower your fasting glucose significantly. That takes precedence to your physique, your hormones, and your SHBG for a period of time, so long as you can come back to a moderate lifestyle of reintroducing carbs properly with good protein and fiber, hydration, etc., and not go back to that pre-diabetic or type 2 diabetic state, and then worry about adjusting the stuff that was possibly impacted over that short term of keto. If you're going to live a ketogenic lifestyle, and I know your good friend Al Reeves over in London would probably disagree because he's keto, and it works for him, and that's great. Look, it's much like hormones. Nutrition is not a one-size-fits-all. I happen to like carbs. My body performs well with carbs. I need carbs for the gym. I get literally hypotensive and hypoglycemic quickly. I don't feel well. I get nauseous if I try to lift without carbs. It could be a matter of adjusting, which I don't really feel the need to go through a period of adjustment, or it could be just that my body just does well with glucose. At the end of the day, we all need glucose to survive. That is the only currency our body recognizes as a form of energy. Whether you get it through gluconeogenesis, whether you get it through lipolysis, whether you get it through any other means, you still need glucose. I just rather take my glucose directly. Some people don't. I have always stayed fairly lean, and I can get very lean when I need to, and I still consume carbs. On show prep, I often eat 180 grams of carbs a day. Everyone's different. There's no right or wrong, okay? I'm not a huge fan of keto as a lifestyle for one reason. People come to me saying, should I do keto? And my question is why? And they say, I want to lose weight. The answer is no. You don't need keto to lose weight. You need a caloric deficit, and you need to understand the ins and outs of it. Restricting your carbs completely for the sake of weight loss is a flawed approach. If you have other purposes and other reasons to go keto and you understand them, I'm not going to dispel this diet as a whole and say don't do it. Do it for the right reasons.
At what point do you stop experimenting with your TRT protocol to relieve ED and start daily cialis?
I can give you, there's different opinions on that. The American Urologic Association does not recommend testosterone as a primary treatment for ED. It's necessary but not sufficient usually. In some guys, it's sufficient. So, that's it. If you get to symptom resolution on your TRT, you're feeling better, but your penis isn't working, why not add daily cialis? That's what I would do. Guys aren't usually going to want to tinker for a year with their TRT if they're not getting erections, right? Like usually within the first 6 to 8 weeks of TRT, if it's a decent protocol, you're going to notice improved libido, morning wood, all those things. If you were getting no erections at all, if you had actual pathophysiologic ED prior to TRT, it's probably not going to fix that. If you've got diabetes or if you had a pelvic injury, or if you've got, you know what I mean, had a prostatectomy. Well, that's not going to fix it. So it's a very subjective question. It depends on the person, depends on what they had before TRT, you know. Yeah, but I wouldn't write it out for a year if you're on a decent protocol and you feel better and you still can't get an erection. I mean, you obviously need to look into other causes for the ED as well. Blood pressure medicines, psych medicines, there's all kinds of stuff, medication that'll kill your erections, anxiety, performance anxiety. But even in those situations, the daily cialis can help, especially if you can't come off those medicines, your doctor won't let you or whatever, and there's no contraindications to take in the cialis. I would absolutely add it. I love it.
Someone asked, what are the indicators of insulin resistance as a patient and what your doctor would be looking at? Bill?
Indicators of insulin resistance. So for diabetes, there are really several markers. I think if your fasting blood glucose is over, is it 130, Jordan?
They change it all the time. Yeah, it used to be over 100.
125, 130. Then you got the ones that say, well, if your A1C is over 5.7 to 6.2, you're pre-diabetic. If you're 6.3 and higher, you're officially type 2 diabetic. Then they run the glucose tolerance tests over several hours. So there's different markers to determine insulin resistance. At the end of the day, it really comes down to looking at the full picture as well as how are you feeling. Insulin resistance isn't really something you feel. We find pre-diabetics almost daily when we run labs for guys that come in for hormones. Mm-hmm. And they had no idea that they were heck, we found guys with A1Cs of 7.2 and they didn't even know. And this guy is a hardcore diabetic and he's only getting worse and they didn't even know. So it's not something you necessarily feel. I mean, diabetes is a terrible disease and it causes a ton of harm in many areas of your body, but a lot of that takes years to manifest. So it's not something that it's like, well, my A1C went up, 1.5 points in the last 6 months, and now I can't get out of bed in the morning. You're going to start feeling things over time. And usually it's only when you have an issue like erectile dysfunction or numb fingers or any of that stuff that you're going to start coming in and saying, well, what's going on here? And that's when they'll discover it. In well visits, you're pretty much only going to be told, well, clean up your diet, or maybe they'll give you some metformin. But that's really it. You're not really going to be given a plan. You're just going to be told, eat better or cut your sugar. So I don't think there's a clear-cut marker. I'm sure, endos who manage diabetes for a living probably have their own array of tools of what they use to assess. But there is different schools of thought on how to really consider. I mean, no one will debate that if your A1C is a 10, that you're not a diabetic. I mean, that's just silly. If your fasted glucose is 300, I mean, you got a problem. But the actual markers of where we say you've crossed over, that's really more subjective for the provider to say. But I like to catch problems before they occur. At least when we see them trending, I like to kind of have a conversation and not just say, hey, do this or eat better or stop doing. Give them a damn plan. Like, tell the guy. People don't understand what eating better means. Right. They don't. Recommend some sort of a plan. If you don't know it, refer them. Mm-hmm. Refer them to someone who does. I mean, I make meal plans for guys every single day. And then they check in every single weekend and we go over, I don't tell guys to count macros or calories or any of that. I do it for them. I tell them what to eat and how much based on the foods that they select. So it could be done. Adherence is the key, and people will only adhere to something that is fitting into their lifestyle. Once it becomes too complex, it all goes out the window, or it's good for a week or two and it's done. So.
And just to add to this, it's a massive problem. And I'm seeing it more and more in younger guys that don't even really realize it. And a lot of them you wouldn't look at and think they were insulin resistant by just their body habits, right? And it's a lifestyle thing. It's a toxic food thing. I mean, all kinds of stuff. Low T thing, which could be cart before the horse, but they could have low T because of all this. A lot of them do. But regardless, it's a massive, massive health problem. And it'd be great to have a way to catch it when you're in that early insulin resistant stage before they even have a symptom. That's when you want to find this stuff and they can correct it. A lot of people don't tend to take diabetes seriously until it's really wreaked havoc on them. And even then, a lot of them don't take it as serious. It's an awful disease. Awful.
3 years ago, I was pre-diabetic. I was on a bulk phase using growth hormone analogs, eating, cups of rice and potatoes every day. And my A1C was 5.9. Yeah. I fixed it in 6 to 8 weeks, but I was pre-diabetic and I walked around with, abs and looked okay. And you'd never guess. People assume diabetics are overweight and tired. And, It's not always the case.
No, and GH obviously throws a wrench into that. A lot of people now wanting to take peptides need to be careful, obviously, with that kind, or MK677.
That's the worst for insulin resistance.
It is. I agree. I took it, and my fasting blood sugar went up to 100. I was like, I'm not doing this. No way. And it wasn't worth it. I felt like crap on it anyway.
Well, an agonist is going to make you raid the refrigerator at midnight.
Yeah. Yeah.
The only time I would say it's indicated, honestly, if I really had to, it's if you got a guy who's 5'9" and he weighs 140 and he says, I cannot eat.
Yeah.
The guy will put on 10 to 15 pounds in 3 months.
Yeah.
Right. And then get him off and fix his metabolic profile. But other than that, I think it's a terrible drug, ibutamoren and MK, however you want to call it, where it comes from. But I don't like it. I think there are much better ways to increase IGF-1 and get the desired effect. Yeah. It blows my mind. Guys think they're going to cut on it,
Good luck.
Yeah.
We get a lot of questions about personal protocols, T levels, and so on. I propose, guys, you ask again and post those questions with your labs maybe in our Facebook group with the same name as this channel, because we cannot take all your personal stuff in here. Someone asked how to raise libido in a 42-year-old woman. She has morning fasting cortisol of 580 nanomoles per liter, that is high, and testosterone of 1 nanomoles per liter, kind of low. She's thinking about supplementing testosterone and DHEA.
I think with women, you need to first assess, is she pre, peri, or postmenopause? At 42, I would hope she's pre. Some women go through surgical menopause, so it's really silly to assume. You also have to consider that the blood draw on a woman runs a lunar cycle. So if this was in the follicular phase, in the ovulation phase, in the luteal phase, her hormone levels are going to be at different levels because the estrogen tends to peak towards ovulation. It tends to come down after ovulation when LH peaks, and then you have the progesterone spike that begins right before her next cycle begins. So knowing when the blood draw was done on a female is extremely important, especially if she's not on hormone therapy. And then you have to factor in if she's got elevated cortisol, she's got to look at her adrenals, lifestyle, etc. Is she under extreme stress? I will tell you, stress is the #1 libido killer out there. Hormones aside, nobody wants to have sex when they're stressed. That's just human nature. So if her cortisol levels are at a chronic state of elevation, she needs to address lifestyle. What's her sleep quality like? What's her situation like? Is she in a relationship that she's, happy with, unhappy with? There's so many factors that go into libido. Is probably the most complex thing that we face.
Yep.
Because you're trying to get into someone's psychological state of mind and assess what is wrong. It's not always hormonal. It's not always physical. It's not always psychological. It could be a combination of different things. And it's like playing with an equalizer that's got 15 channels on it and you don't even know where to begin.
Yeah.
Do I need more treble, more bass, more mid-range, and how much? It's literally such a balancing act that requires a much greater assessment than just hormones. But if we're going to oversimplify this, if she has low T, and I'm going to go on a limb and make assumptions here because we don't have more information to go by, but if this is her true peak levels and she is premenopausal, and I'm only assuming this because of her age, I have seen a drastic increase in libido in females who otherwise have well-functioning endocrine systems and regular cycles where their estrogen and progesterone levels are sufficient, and they supplement a low level of testosterone cypionate twice a week, like to start at about 5 milligrams twice a week for a total of 10. And you could always double that up to 10 and 10 if need be. You can go 6, 7, etc., up to 10 and 10 for a total of 20. But we have found some symptom resolution for a low libido on women in their 30s and 40s who are still ovulating by going with testosterone cypionate twice a week at a very low dose. It's worked well for a lot of them. And again, I don't know if this individual happens to be in that boat, but barring any other pertinent information that she didn't provide, I'm just going to make these assumptions in case it helps anyone else.
Nice.
Someone is asking about acne on TRT, but as I answered in the chat box already, I made so many videos on acne on TRT about supplements, food, hygiene, and the treatment of it locally, topically, and with cyclines and isotretinoin, Accutane in the USA. So check out those videos. I made several on the same topic. Someone did another super chat tip. Can I use HCG 1000 micrograms a week long term with low dose Proviron to raise my free T to delay TRT? Can I increase more fertility years after I use HCG?
So he's not talking about micrograms, he's talking about IUs, I assume. However,
He said 100 micrograms. I'm not exactly sure what.
I don't know.
Under that, he writes 1000.
Oh, he changed it. Okay. Oh, I see. Yeah, yeah.
Once a week. Very fast acting. Don't use it once a week. So HCG, as we know, is an LH analog, and Proviron is an FSH analog. So what you're doing is you're essentially replacing your pituitary gonadotropins. But what's the end game? Because you're suppressing both. So what is the end game? How do you come off? You're saying delay the onset of TRT. Great. For how long? And when do you plan on getting on TRT, if at all? Because you come off of these medications, you're now in a suppressed state. Jordan, I mean, any feedback on that?
I guess I need to know the reason for this. Does the person need TRT? Is this somebody that needs it and they're trying to avoid it? Is this a fertility thing, a fertility protocol? Like, it just depends on, I mean, overall, I think it's a terrible idea, but I don't know the context of the question. I mean, you're not gonna get a great testosterone boost alone from HCG. HCG monotherapy is crappy for that. Proviron's not gonna increase. It decreases your testosterone levels, even though it doesn't affect LH.
It lowers SHBG significantly.
That as well.
That
So
is what's indicated for
yep.
TRT.
I think you can feel long term. No, I think no. But I don't know the context.
I think this is a classic fertility protocol, to be honest, and nothing more.
Yeah.
I propose we end this live stream in 10-15 minutes, guys, if that's all right with you. So let's take the questions in the colored boxes that the people actually paid us a tip for. So should someone donate blood before TRT if they are on the high range naturally with their hematocrit?
Oh God, hematocrit. So Jordan and I have a video about hematocrit. It's 45 minutes long. Watch it.
Check it
Hematocrit
out.
in and of itself is transient. Short answer, no. You want to know why? Watch that video. Need hemoglobin and RBCs. Need a full platelet differential panel as well. Need to find out lifestyle factors that may be causing a false level of elevation, as well as realistic levels of elevation, such as smoking, hypoxia,
COPD.
sleep apnea, COPD, anything like that. There's a lot more assessment that needs to go into this. I would be cautious taking someone who's naturally elevated, as he calls it, and starting him on TRT without first assessing why he's there to begin with.
And define elevated. That's the other thing, right? Like
My hematocrit hit 50.
Yeah, that's not, to me,
Fine.
I'm like,
right now, let's go.
yeah, no. I mean, there's some people that are told that if it's over 47, they're high. And I mean, I've seen labs that go all the way up to 55. I'm like, so which is it, right? It's like, it's completely arbitrary.
You want to lower your hematocrit? I just put away a bottle, and I got another one on the way.
Yeah.
My hematocrit's going down 3 points while we're doing this live feed.
Mine from 58 to 53 on 2 different labs just by hydrating beforehand. So, yeah.
In the same question, also, any tips on getting over the anxiety to start TRT? I am afraid it will spike my health anxiety.
25 milligrams of triactin works like a charm. And if you don't know where to get triactin like an adult.
Oh, man. I was waiting for that. Yeah. Yeah. No, I mean, you can't think like that. You're not going to feel better starting TRT. Like this is what we talked about earlier, right? You're going to induce all these bad side effects just from expecting to have them. If you think you're going to have anxiety on TRT, guess what? You're going to have anxiety on TRT. You've got to change your mindset before you ever start this. It's one of the hardest things to do. And I've got a few patients that are like this, and it's very difficult to get them to just trust the process, right? It's no different from people that I'm sure Gil deals with dieting, right? And they want to tinker. They don't think it's going to work. They don't trust the process and just do it, right?
I hate to sound harsh. I don't take on those people.
Yeah.
For nutrition,
yeah.
If they're going to be combative, non-compliant, inquisitive is okay if you want to learn. Inquisitive so that you can build up ammo to tell me why I'm wrong, then why are you paying me to advise you?
Yeah.
I don't have the time to babysit or fight with people. So if they don't want to do what has been proven thousands of times, then please don't even start, because you'll get frustrated and quit. I'll get frustrated for the waste of time, and someone else who could have used the help didn't get the opportunity because you took his spot. So look, at the end of the day, I understand that when you're starting out, you're probably at a low level of testosterone. You're probably already suffering anxiety. And I understand that the thought of all this stuff you're reading, jokes aside with the whole triactin joke, is, realistically, I get it. People do have anxiety when they start, especially when it comes to self-injections.
Mhm.
You need to take a deep breath, and you need to understand that what you're doing is something that, for starters, you didn't ask to be in this position. You are here. And you have two options: turn left or turn right. Turn right means you continue the current path. You're obviously asking these questions because the current path is not something that you want to continue on, or you wouldn't have even brought up the question. If you turn left, you have an opportunity. That opportunity likely will turn out to be better if done correctly, because there's a ton of case studies that came before you to prove it. And if it is worse, you always have the option of making a U-turn and getting back to the intersection and continuing on the old path.
Yeah.
So relax with the anxiety a little bit and understand that if you trust the process with the right guidance, chances are greatly in your favor. Okay. So if you stop and think and put in perspective and get the hell off Google, your anxiety levels are going to be reduced.
That's the key. I totally agree. Yeah. Don't go into it expecting badness. Don't get on the internet first and start reading. I mean, it's fine to educate yourself, but don't overanalyze it. I mean, when I got on testosterone, I mean, I felt better almost immediately because I knew I was doing something positive for myself, right? And I mean, just even going through that, I never once, not once, worried about bad side effects. Not once, never crossed my mind. And the guys I know that do worry about it, it stays with them, and they end up tinkering for a long time until, and it's the same with the AI stuff. It's the same mentality, right? They think they're going to have high E2 sides, and so then they do, even though they're not real. And until you convince that person to change their entire paradigm on the AI use, they're never going to feel better. And magically, when they change their mind and get off it, they feel better, right? Well, what were they having earlier? Were they having high E2 side effects? No, obviously not. I put a video, you can search for it on our group, about the nocebo effect. And it's a great video, and everybody needs to watch it. This applies to everything in life, not just hormones, right? I mean, I had this talk with cancer patients when I have to tell them they have prostate cancer. And, it's a fork in the road moment, right? You have to, people, and especially if it's a curable thing, treatable, you either address it, right? Or you go down this downward spiral of depression. I mean, and what good is that going to do your health? So the people that do best are the ones who think, I'm going to tackle this and I'm going to be better for it, and does it always work? No, obviously not, but they're still better off having that attitude than they are just going into this cycle of depression, and that's just going to hurt their health overall. So it's the same thing with this.
Yeah, I did some work a couple of years back with a biochemist named Trevor Cashy, and he did his PhD dissertation on the placebo effect of medications. And I watched like a 3-hour presentation that he did once on it, and it was amazing how powerful placebo really is.
Yep.
Really, really, really powerful. In some cases, it actually surpassed the effects of the actual medications.
Absolutely. And that's a problem, right, for the pharmaceutical industry and for all that we do. And we think that we're fixing things with medicines. No, you're not fixing it. If it's not science. Science, it would work all the time, every time. You'd have a cause and effect. This is not. You've got probabilities and statistics and placebo and everything else mixed in. And half the time, like I say, you're just suppressing symptoms. You're not doing anything good, honestly. So.
If everyone's still watching, join our Facebook group, TRT and Hormone Optimization. These great guys are in there, as I am myself, to ask all dermatological related questions. I see some questions concerning thyroid as well. If you go into the Facebook group, we have there Justin Gross. He makes videos for us concerning the thyroid because he's very much into that. So you can ask the question there. Maybe one last thing. Can someone using HCG monotherapy as an alternative to TRT combine Clomid with HCG to further increase my levels to high normal? Will it work or no?
Are we still on?
I feel like we just talked about this. Oh, man. This is...
Any other questions, Steven?
we're not trying to be rude.
Don't do HCG monotherapy, period, end of story.
Okay.
Use Clomid, period, end of story. I hope that answers that.
Okay. Another thing then. Will I get red flagged if I change my TRT dose without my doctor's consent? Something for you, Gil. 150 total and 7 free, and he puts me on 100 every 2 weeks, planning to just do
Don't
100.
change your protocol, change your doctor.
Yeah, that's a no-brainer.
Yeah.
That's a castration recipe, is what he's giving you.
I'm not going to sit here and ever tell anyone to use medication against the way it's prescribed. I don't think Jordan would say that to anyone either.
No.
If you're prescribed something, you have the right to refuse the medication. That is a right that you have, but you don't have a right to use it against the way it's prescribed.
Yeah, you need to bring it up with your provider.
You need to bring it up, but I will advise you to change providers, not attempt to educate your current one.
Yeah, it's
You're paying him to treat you. He's not paying you for an education. And I can promise you that the provider you just mentioned knows zero about hormone therapy.
Agree.
Okay, if you see any other questions, Jordan, Gil, that you really wanted to take on.
I don't see the chat box. Where do I find questions?
Oh, it's on the live stream on the YouTube.
Oh, I'm not on there, so I'll let you guys.
I wanted Gil to address the Barry's comment that said Jason Fung says calories in, calories out is a flawed weight loss strategy.
I didn't dare ask that to Gil.
Ask away. Great. What's his alternative then? What is not a flawed?
It's 0 carbs and fasting is not. It's going to overcome the calories in, calories out. I think that's
0 carbs and fasting. So let me ask you a question. When you eat 0 carbs, you are removing 4 calories for every gram of carbs that you're no longer eating. And when you're fasting, you're removing 100% of the food that you would be eating during that time period. So if I have 24 hours and I'm spending 8 or 16 or however they do this intermittent nonsense fasting, I am now cutting 33 or 66% of my allotted eating time. And I am also removing a third of the macronutrients that are available to me. What am I really doing here from a scientific standpoint? I'm reducing the amount of calories I'm taking in. So am I still consuming less calories than I'm expending by utilizing these 2 strategies? Yeah. The answer is yes. So is it the strategy itself so you're telling me now that I can literally sit here and eat 0 carbs and fast for 8 hours. And then the other 16 hours, I can eat 6,000 calories of fats and 2,000 calories of protein and lose weight?
Yeah, exactly.
I can eat 8,000 calories a day of fats and protein and I will lose weight because I fasted and had no carbs.
Yeah.
I don't want to try it out on my body, but I will welcome anyone to try that out.
I mean, if anybody's got some actual well-done studies, head-to-head, controlled, like showing that truly a calorie deficit versus a surplus, and his method in a surplus, people actually still lost fat, I want to see it. I mean, I really do. I get a lot of the reasoning for some of what these guys push because of the processed foods, and that's what they're against. And I get that, but that has nothing to do.
They're trying to develop a level of adherence with a small-minded individual who doesn't want to take the time to educate themselves on the actual nutritional aspect of what's happening in their body. So they're saying, how about this? I noticed that you're abusing this. So if I take this out of the picture, I will put you in a caloric deficit without asking you to keep track.
Yeah.
So let's not do this anymore. And now you're in a caloric deficit, but I'm not going to use that word because you won't buy my book if I made it simple.
Yeah, they'll say it's the fasting that did it instead of the fact that you.
I don't sell books.
Yeah.
I don't sell videos. This is free. Okay? I will sell my time to work one-on-one with an individual. If you want to take what I say and use it for the masses and learn from it, by all means, don't send me a penny. Take what I'm telling you and run with it. If you want me to babysit you and hold your hand for 3 months every single week, you're going to have to pay for that. I am not going to tell you to go out and buy my diet book or go out and subscribe to my video plan that's $9.99 a month and then tell you this magic diet and how everyone else is wrong. So again, I'm not trying to like undermine Dr. Fung, but he sells books and he sells these subscriptions, and then he's going to tell you that calories in, calories out is moot because you just need to fast. Okay, then explain the science behind that if you
want. I want to see some good studies on it. That's all. I mean, I really do. I don't get it, but that's that.
I've cut for a show on 180 grams of carbs. I was at 4% body fat. I could trace a vein from my ankle all the way up to my neck.
I lost 53 pounds in a year just cutting calories and still ate carbs. Carbs aren't the devil. I mean, I think that's where a lot of these guys, you know, they push the whole insulin hypothesis that it's the insulin that's making you fat, or it's the insulin that's causing the problem. It's like, do they realize protein stimulates insulin as much as a carb meal? Like, so are they recommending no protein? I mean, and I'm not trying to straw man them, because maybe I don't know their whole argument. So I don't mean to sound like that. I don't know. I don't understand. When they say it's not about calories, that kind of is a red flag to me.
I throw 80 grams of cornstarch into my intra-workout drink.
Yeah.
And it keeps me lifting. Otherwise, I get lightheaded.
And there's plenty of people that eat lots of carbs and aren't diabetic. Freaking sumo wrestlers, guess what? They're not diabetic. They're not. They're massive. They work out. They have tons of muscle mass. They eat a shit ton of carbs. They don't get diabetes, right? So there's more to it than just the anti-carb stuff, you know. And I agree, some of this processed carb crap, yeah, because it's processed crap and it's easy to overeat it. But if we're talking about pure fat loss and not health, you can lose fat in a lot of ways.
Difference between a jelly glazed donut and a baked potato or a cup of rice.
Right. And I think that's where
they're glucose in the body. The process by which this happens is
right. I think that may be
one last question, just to annoy Jordan. Do you guys even get your E2 checked if no AIs or side effects?
I don't.
I don't know the last time I checked it. Years ago, and that was just for kicks.
Do you check if it's raining in Italy to know if to wear an umbrella in Belgium? It's not relevant to what's going on in my body.
Well, again, this is something that I think guys still have the hard time believing. And maybe it's just because we're the few that are talking about the intracrine paracrine nature of estradiol, right? That serum level is not telling you what's going on in your brain versus your bone versus your penis versus your heart. It's meaningless. It really is. I can understand if it's low and you're tanked, then you're probably low. Not necessarily if you don't have symptoms from it.
If I suspect it's too low, I may test it, but I don't test it because it's high. It's never high. It can't be high. It's self-regulated.
It moves with testosterone to a point, and then it plateaus off. And why check it when I'm not going to do anything about it? That's a rule in medicine, period. Why don't check something if it's not going to change what you do? Mm-hmm. So why would I check E2? I mean, for the most part, if I'm never going to give somebody a aromatase inhibitor, I'm not worried about the estradiol that they're making from their testosterone. I'm just not.
For everyone watching this who doesn't know what we're talking about not using AIs on TRT, watch the extensive multiple videos we did on them. So I will link to them here. Okay, well, let's end this. Jordan, Gil, thank you so much for your time. It's really appreciated. I guess all the guys have had a lot of answers. And if there's anything more to answer, please repost those questions in our Facebook group. Thank you so much and enjoy the rest of your weekend, guys.
Thanks, as always.
Thank you, man. Appreciate it.